Allow me to introduce our very own Prof. Kgomotso Mokoala. In this month of August, celebrating women, we celebrate your achievement and success. You are inspirational. Your remarkable contribution as the woman in nuclear is encouraging. Prof. Mokoala is an associate professor and the head of the unit of nuclear medicine at the University of Pretoria and Steve Biko Academic Hospital. She is the South African Society of Nuclear Medicine Council member and serves as the nuclear physician representative in this committee. She is currently the academic chair of local organizing committee for this Congress. At the university level, she is a member of the MET and transformation committees. She obtained her PhD last year, titled Validity of Tumor Hypoxia, Assessment Using Gallium-68 Nitramidazole in patient with cervix cancer. Her research activity has produced more than 30 articles that are published in ISI-indexed peer-reviewed journals and 21 abstracts that are presented nationally and international in conferences, and 4 book chapters in well-published publishers. She reviewed in 5 journals, which are European Journal of Nuclear Medicine and Molecular Imaging in Frontiers, and also World Journal of Nuclear Medicine, Aging Journal, and lastly, Scientific Reports. We welcome you and thank you.
Thank you. Good morning. Thank you for the welcome. Thank you, Chase. I will be speaking on a topic which is taking us back to our roots, which is the core of our theme for this Congress. So I'll be speaking to Rhenium-188. These are my acknowledgements. These are the people that we work with. In everything that we do, we don't work alone. No man is an island, and we work as a team, and that's how we become successful, and that's how we go far. So I'll just start off a bit of background on what Rhenium-188 is and its properties. So it's a group 7 element in the periodic table. It's a beta-emitting isotope, and it's also got a gamma emission as well, which is good for dosimetric calculations. It's got a half-life of around 17 hours. It's 16.8, but I've just rounded it off to 17 hours. And it's got a penetration depth of around, well, it ranges, but the maximum is around 10 millimeters, and the minimum is around 2 millimeters. Rhenium is produced, or we get it from a generator, which the main mother isotope is tungsten. We don't usually have it in departments, but we get the rhenium as a byproduct of it from the tungsten generator. So rhenium is not new to us, like I said, because we're going back to our roots. It's something that's been used in the past, and I think Prof. Bascom also highlighted some of the uses of rhenium when he presented his CME on Thursday. So some of the uses go back to when it was used in hepatic carcinomas, as a bone palliation agent, of which is still being used, or more so, it's more in radiosynovectomy than in bone palliation. And then it was also used in intravascular radionuclide therapy, which I think was very fascinating. And it's quite interesting to see that some of the uses of our products sort of die down. So I'm concerned as to what it is that we're not doing right. I think from a radiology point of view, things seem to be advancing and they seem to take over some of the things that we do, or some of the sort of applications that we do. Perhaps it's because they advanced the equipment. So we need to relook at what it is that we're doing and how we can do it better so that we can still be useful to the clinical, to the clinicians. The last one is the one that I'll be focusing on. That's Rhenium-188 in the treatment of skin cancers. This was just an image, like I said, I thought it was interesting to see that, this is what it was used for. It used to help prevent restenosis after stenting of coronary vessels. So obviously that is not being used anymore. In terms of therapeutic nuclear medicine, this is not new. And again, we've been hearing a lot about Marie Curie. She discovered radioactivity or radium in 1898. And then around 1901, Henry Becquerel inadvertently discovered the use of radium for treatment of skin lesions. So he had radium in his pocket and he realized that he had a skin burn. And then later on, Henry Alexander Danlos then took that into the clinic. He was a dermatologist and he started treating skin lesions such as systemic lupus erythematosus, and then from there it was taken on into other lesions such as tuberculous lesions and skin cancers. And this is some of the early work that was shown that radium was used for. So this is just taking us back to where it's all started. In terms of rhenium now, rhenium is used to treat a variety of non-melanoma skin cancers or skin lesions. So we use it to treat basal cell carcinoma, squamous cell carcinoma, Bowen's disease, which is a pre-malignant lesion for the squamous cell carcinoma, so it's essentially like a carcinoma in situ, and extramammary Paget's disease, as well as actinic keratosis. This is just a graph to show why rhenium is useful in these skin cancers. I think when I started, I did say that the penetration depth of rhenium is around 2 millimeters with a maximum of 10 millimeters, and that's why it's useful for skin lesions. Let's see if I can point. Is it the red one? Oh no, it's not the red one. Okay, so anyway, as you can see on the graph there, the deeper you go into the skin layers, the less the activity becomes. So in the early stages, rhenium was used to treat skin cancers in the form of a skin patch. So they used papers and patches, so where they would embed these papers and these tissues with rhenium, and then they would apply that on the skin lesions. But over time, things have changed, and there have been newer ways that are more flexible, that are less cumbersome and less time-consuming. So we've got the rhenium, what they call the OncoBeta, I think has created a equipment, which I will show later, which is more flexible and easier to use. But it doesn't stop, centers that have the capability or don't have the equipment to still use the rhenium papers and the rhenium patches because they work quite well. So again, that's just some of the papers. And this is just a summary of a few of the work. Well, it's mainly like a consolidation of the work that has come out of Italy, where they've shown how well the rhenium therapy has performed in non-melanoma skin cancers in over 55 patients that they followed up over 3 years. 98% of them only needed one session and were in remission post that one single session of therapy. The one patient was still under treatment. I think he didn't do quite well, and then he went for surgery. This is a chapter that we wrote, that we were invited to write on this skin therapy, because we do that in our center, and we also presented our work at the EANM. So I'll just go a bit into detail about how we actually do this or perform this rhenium skin therapy. So we have the 3 pieces of equipment there. Okay. So this is the waste bin. This is the dose where we measure, the measuring station. And then this is the actual area where we collect the carpule. Okay, so then how do we do it? So we work in a multidisciplinary team setting. We don't work alone. We work with our physicist. We work with the dermatologist. We work with plastic surgeons. Those are the main 3. We obviously also sometimes work with oncologists, but the main people that we work with on site are the dermatologists and the plastic surgeons. So what they do for us is that they come and mark the area. I've used an example of a keloid, but on this, just to show the procedure, but the dermatologist then comes and marks the lesion for us, giving us a 3 to 5 millimeter margin, depending on the pathology. And the reason for that is that it's taken from the surgical way of treating skin lesions where they use a margin because beyond what the eye can see, we anticipate that some of the cancer cells have spread already in the skin layers, in the tissue. So we then apply a plastic foil because we don't apply the cream directly onto the skin, and then after that we apply the rhenium. What we then do, the physicist, we have a software that we use, I think it's called VARSkin. We input into the system how deep the tumor is, which is what we would have gotten from the histology, so the depth of the lesion. We put in there how big the area is, and then how much activity we've applied. So then the system calculates how much time the patient needs to sit with this cream on for in order to deliver 50 grays to the deepest margin of the tumor. Then from there, when the time has lapsed, we remove the foil and the patient goes home, and we then follow the patient up over a specified, we've got a protocol that we follow. I'm just going to show a few examples of some of the patients that we've treated. This is one of the patients. He had Bowen's disease. I think one of the lesions was Bowen's. It was a combination on his histology report. It was Bowen's and squamous cell carcinoma, as well as BCC. So we then treated him, and after a single session, we can appreciate that in the top, this was before treatment. That was 2 weeks post-treatment. That was around a month or two. It was a month after treatment, and that was 3 months after treatment. So we can see that the results are amazing. This is another patient that we treated who had a BCC on the right shoulder. And again, you can appreciate the progression over time. That was pre-treatment. This is a few weeks. So it sort of gets worse before it gets better, but the outcomes are impressive. This is a patient. She had 2 lesions. I only just showed the one. So that's another thing or advantage of this rhenium that we use. You can treat more than 1 lesion in one setting. So this patient had 2 lesions, but this is the one that I'm displaying on the right chest wall, and this is how the outcome was for that lesion as well. So of course, this is some form of radiation that we apply on the skin, so we expect to get some, I don't call them complications or side effects, it's the sort of expected radiation changes. So we have skin redness, as you've seen from the examples. We also get inflammation, bleeding sometimes, hardly ever. We haven't had any patient that has complained of bleeding, except of course if a scab falls off, then maybe there will be a bit of bleeding. They get some superficial vascular complications, infection, skin necrosis, and the main one is depigmentation or hypopigmentation. When we follow the patients up, we use a grading of some sort to say what the skin changes look like, and this is based on the oncological follow-up based on the external beam therapy. So we grade the radiation dermatitis and all the other changes that we see. So beyond skin cancers, the superficial skin cancers, we have also looked into treating keloids with this. And this is important in our setting because keloids mainly affect people of darker skin color. So obviously Africa, India are the countries with the most prevalent or most, prevalence of keloids. So we have then looked into how we can assist in that setting. I've sort of just given a brief background of what a keloid is. I'm not going to go into that because I may run out of time. Currently, nuclear medicine does not feature, and that's where we are going to try and get it to be one of the options in terms of therapies for keloid patients. Because from this list of therapies, we know that there is a high recurrence rate in any of them, whether treated as monotherapy or as combination therapy. And this is just a table that just shows the outcomes and the recurrence rates in these patients in using the different forms of treatment. This is a study that was done in India. They used patches, but regardless, like I said earlier in the beginning, even if you use patches, the outcomes are still quite good. So they used patches. The only disadvantage was that with the patches, the patients have to come over several days. So they cut out a patch, okay? So what happens is they measure the area first, look at the area, and then embed a piece of tissue with rhenium, then go put it on again and cut it exactly to the shape of that lesion, apply it there. The patient sits for 3 or 4 hours and then goes home, comes back the following day, and this happens for 3 days. So obviously that is not quite ideal. And that is similar to radiation therapy in terms of external beam, because patients come over several sessions over several days. And that is what we're trying to run away from. So in this study, they had 15 patients. Like I said, they have more than one session. But the nice thing is that they didn't report any adverse events or any side effects or complications in terms of the treatment outcomes. And all patients reported symptomatological improvement, and there was no recurrence after following the patients up for 3 years. So this was also another work that they produced. And then in terms of our local experience, this is one of the patients that we treated. She had multiple lesions. Like I said, unfortunately, the hypopigmentation is a side effect, but the patients do report improved symptoms, and they are happier with the improved symptoms than with the hypopigmentation. This is also another case, again. So one of the things that we've learned over time, or with the experience that we've gotten, we realize that, and this goes back to what I've said in the beginning about the properties of rhenium, the bulky lesions are difficult to treat, and then patients have to come back for more than one session. So what we've then sort of done is changed our protocol. So what happens now is that patients with bulky lesions go for debulking, and then they come in because we know that post-surgery, they are likely to develop a keloid. So they come in after surgery around 4 weeks or so, just at that point of healing, and then when the stitches are out. Then we apply the rhenium, and then we follow the patients up. So this was one of those patients that we started that protocol, and you can see that this was post-surgery, then we applied rhenium, and this was immediately post, but then obviously, like I said, it gets worse before it gets better, and we have the hypopigmentation, unfortunately, as a side effect. So this is a case I brought because nothing is perfect. We had this patient who had, unfortunately, a keloid in not such a nice area. So we treated her, and you can see at the end, initially she did very well, but we don't know, we believe, we can only hypothesize that perhaps she had some sort of infection or inflammatory region, because she came back and she's developing recurrence along the edge of where we treated. So these are some of the challenges, and these are the things that we need to try and find solutions to and work around as to how we're going to move going forward. But out of the patients that we've treated so far, she's the only one in terms of the keloids that has come back with a complaint of recurrence, or at least evidence of some form of recurrence. The others have not. So perhaps this one, I think it's also because there's hair follicles there, it's in an area that can, get irritated easily, ingrown hairs, all those things can possibly contribute to why we are having recurrence in this patient. So lastly, I think I'll just speak to the challenges and opportunities that we have when we're looking at the rhenium skin therapy. So on the left are the challenges, and on the right are the opportunities. And we can see there's more challenges than opportunities. So we need to create a balance or have more opportunities than challenges. Nonetheless, the costing and the funding model needs to be improved, because at the moment it appears, and I think it's because of the logistics. So rhenium, the one that we get currently, is coming from Finland, so it gets shipped in. So the logistics of having all of that, I think, contribute to the cost. So if we were to have possibly production locally, that may minimize or reduce the costs. Secondly, the referrals, they are a challenge. But I think with Word, we have gotten a bit of traction. So people are referring patients now. The dermatologists and the plastic surgeons are seeing the value of this treatment, so they are sending patients. And the follow-up. So in terms of follow-up, I think what we struggle with is that patients, as soon as they, because we try to follow them up for like 2 years, at least to make sure that nothing has happened. So a lot of them, as soon as they are at that last photo that you see, then they disappear off into the sunset. Only when problems occur, then they come back to us. Then the other challenges with the keloids, I think it's something that also came up in one of the webinars that we presented. How do we know that we've actually, healed or killed all the fibroblasts, the abnormal sort of fibroblasts? We don't know. And with keloids, it's difficult because we can't rebiopsy, because then you're going to stimulate that area again, irritate that area again, and you can cause another keloid to form. So the only thing we can do is just look at, in terms of clinical follow-up, and take it that the Rhenium has done its job. And then the other main thing, actually this should have been at the top, is oncology. Like Prof Setege highlighted, I think yesterday, with most of the nuclear medicine therapies, as soon as it's hit the ground, then nuclear medicine and, oncologists and other specialties start, trying to to pounce on it. So I think we need to find a way to protect the space. And we're not trying to say that it should, but let's find a way to work together. And someone should be trained, like Prof said. Someone should be trained to do a certain thing. They should be skilled, and they should have the competency to do something. So I don't know how certain specialists are performing certain therapies, because I can't just wake up one day and go do brachytherapy. Anyway, the last thing, the research areas, I think because of all the, some of the points I've highlighted, or issues that I've highlighted, I think there are certainly areas that we can look into as to how we can improve our, therapies, and how, what other pathologies we can possibly treat with this. And again, I've also highlighted that opportunities in terms of keloids, because, a lot of the papers that we look at, or a lot of work that we look at, comes from high-income countries, and they come from Europe and America, etc. And they don't suffer from keloids as much. So we suffer from keloids, so we need to put in the work and do the research and find solutions to our patients, for our patients. And lastly, I think I would like to say that Rhenium has been proven to be a safe, safe therapy, and it's got excellent clinical and cosmetic outcomes, as you've seen from the pictures, with minimal side effects. And usually we can treat more than one lesion in a setting, and we can also now apply it into keloids. We definitely need a multidisciplinary team, so we need to work together with the oncologists, with the plastic surgeons, dermatologists, and with our physicists. And we definitely need clinical trials. I think one of our trials have been recently completed, so we eagerly await we're still going to be following up the patients, and we eagerly await the outcomes of that. And you can look forward to also our paper on the keloids study patients that we have done. And this is the team that we work with. And thank you.